Here we're going to talk about lifespan considerations, and that encompasses drug therapy during pregnancy, considerations for the neonatal and pediatric patients, and considerations for our older patients. I thought this was a really great picture to encompass lifespan considerations. This is my now 94-year-old grandmother holding my brand new niece who's now 14, but just a great depiction of bridging your pediatric and your geriatric clients together. Drug therapy during pregnancy is something that requires careful consideration. Not every case is going to be the same, and the biggest message I can relay is that it's really important that the conversation happens one-on-one with the patient and their OB. It's important to also note that not all drugs do cross the placenta, so it's really important that you're mindful and aware of which ones actually can cross the placenta. Nutrients do as well through diffusion, so it's important that you're very mindful of what you're consuming. And if you're not sure, then it's really important to have that conversation with the OB. Typically speaking, first trimester is going to be where the greatest risk to the fetus is going to be, and that usually is because of the developmental defects that can occur during that first trimester. When we talk about drug therapy during pregnancy, there's three main categories that we're going to look at that really are big factors that can either contribute to safe or potential harm during pregnancy. First one, your drug properties. So that's going to include the drug itself, whether the molecular weight, the protein binding capacity, lipid solubility, and the actual chemical structure of the drug itself. The next is the fetal gestational age. So that is the actual age of the fetus itself. So as I was previously saying, your greatest risk is going to be to the fetus during the first trimester, likely developmental defects if you're consuming any drugs that can be harmful to the fetus. It's really important that you don't self-treat, and that big part of that is over-the-counter medications. So even something that you may think is super minor can actually be very detrimental to the fetus. So as I previously said, if there are any questions or concerns, that should always go through your OB first. Don't just assume because it's over the counter that it's safe. So while a lot of drugs actually reach the fetus during the last trimester, it's more dangerous in the first trimester because that is where the fetus is developing and where you can have those structural defects. And then our third category to consider is maternal factors. So the biggest part of that is going to be your renal and your liver function, because your liver function is going to affect your metabolism and your renal function is going to affect your excretion. If mom has any impact to the liver or kidneys, let's say chronic kidney disease or even non-alcoholic fatty liver disease, if there's any disruption to the metabolism or the excretion, that means that that drug is going to be potentiated in mom's system longer, which has higher risk of toxicity, which also means higher risk of toxicity to the fetus. We also have an FDA classification of drugs during pregnancy. Now, any of you that have been recently pregnant might have heard a difference in utilizing the categories. The FDA was trying to understand better how healthcare providers make those decisions with pregnant patients. And so instead of utilizing the pregnancy categories, the FDA did replace the categories with a system called Pregnancy and Lactation Labeling Rule. However, providers still do use the classification of drugs during pregnancy with the categories I have listed here. So for our purposes, we're still going to learn them as it's still something utilized. So we do have Category A. This means that there is no risk to the fetus. Category B, there's no risk to an animal fetus, but we don't have any information on humans. Category C, an adverse effect was reported in an animal fetus, and there is no human testing. Category D is there's possible fetal risk in humans. However, selected cases, there's a benefit versus risk. that we could use those drugs, but there could also be a poor outcome. And then we have category X, where there have been fetal abnormalities and there is evidence that fetal risk in humans can occur. So we should not be utilizing these drugs in pregnant women whatsoever. And you should be familiar with this category and know this. So we're utilizing the same thought process of drug therapy during pregnancy with drug therapy during breastfeeding. It's not even drugs that you have to fully take into consideration, but again, anything over the counter, even certain liquids, foods that the mom consumes can be transferred over to the baby. So it's going to be basically a risk versus benefit because there is a risk that that drug can transfer to the infant. So we really need to make sure we're having those conversations with the healthcare provider, and if there's any question, making sure to ask. When we look at the likelihood of which drugs are going to transfer during breastfeeding, it depends on those characteristics of the drug itself. So the fat solubility of the drug, if it has a low molecular weight, and the actual concentration of the drug itself. You might hear the term pump and dump. Moms will pump but dump that breast milk if they've consumed anything within a certain time frame based on whatever medication it was that they took to ensure that it doesn't transfer over to the baby. You still need to pump to make sure that you don't become too engorged because you don't want your ducts to get clogged. And you want to continue to pump so that you can keep up with your milk supply. And now we're moving into our considerations for our neonatal and our pediatric patients. And that's the cutest photo of my middle niece, Emma, about 11 years ago. With our neonatal and pediatric population, we really are going to have to tailor our care, not just in how we do our assessments, but how we treat and evaluate. In a few slides, I'll go over how to tailor your care based on their age, but it's important that you really individualize for each individual patient. And not only are you managing your patient, but you're also involving the caregiver, parent, whomever is responsible for that child. We do also have to consider how drugs will affect these patients differently because they have an immaturity of their essential organs, their anatomic structures are different, and physiologically they are different. Now that you have the foundations for absorption, distribution, metabolism, and excretion, we are going to apply these principles as to how they are different now in the pediatric population. In regard to absorption, it's important to note that we do have a less acidic environment in our gastric mucosa due to the cells being immature, and it takes about 1 to 2 years of age for those to start maturing. We do also have a delay in our gastric emptying, as well as first pass elimination because there is a reduction in immaturity of our liver cells. There is also irregularity with our intramuscular absorption, which makes things a little bit more predictable and more complicated because it's faster. In regard to distribution, there are many factors that are going to influence our pediatric population. One of the biggest one, body fluid composition. Since our children are pretty much 75% water, what do you think that means? If you said dehydration, you are absolutely correct. There is also a much lower fat content because of the greater volume of total body water. There's also a decrease in protein binding, and we know that if you don't have protein to bind to your drug, you're going to have a lot more free drug, leading to risk of toxicity. And due to immature barriers, predominantly our skin and our blood-brain barrier, we have a higher risk of toxicity because drugs can cross the blood-brain barrier much more easily because of the immaturity. In our pediatric population, we do also have a decrease in our microsomal enzymes, and that is purely due to the fact that we have an immature liver and it hasn't started producing enough. That will improve with age of the child. So the older that the child gets, they're going to have more microsomal enzymes due to their liver maturing, which is another reason why we weight base our medications to make sure that we're appropriately and safely dosing medications for each individual patient. We'll be applying the same principles of excretion or elimination to our pediatric population due to immaturity of our kidneys. This means our glomerular filtration and our tubular secretion are all going to be decreased. There is also a reduction in blood flow, which means less perfusion to the kidneys. That puts us at a higher risk of toxicity if we're not able to excrete or eliminate the drugs. Since we are at such a high risk of toxicity with our pediatric population, we do something called weight-based dosing. All of our medications are based on the patient's weight. There are some medications that we do weight-based for adults, but all medications predominantly are done through weight-based dosing. It's even more important that we know how to calculate dosages correctly with the pediatric population to ensure that we are not either under or overdosing. We are not focusing on dosage calculations and is not something that you will need to know, but it is a concept that you should be aware of, that we do weight-based dosing for the pediatric population. Preparing to administer drugs to our pediatric patients is something that's very important that we take into account, not just the individual patient, but also their developmental stages and where they're at. Because remember, the cognitive function of a child may not match their actual chronologic age. So it's really important that you not only understand the developmental stages, but that you do assess your individual patient based on where they are cognitively, not just chronologically. We also need to make sure that we're doing family-centered care, and that's including all family members or caregivers, whoever is there acting as the caregiver for the child. When working with toddlers, it's possible that they can react violently and negatively to any sort of drug administration. We can't expect that behavior within limits. We do need to provide simple explanations with a firm approach, and we can use imagination through play. So having a little baby doll or a rag doll and using a needleless syringe to show where you're going to be giving the injection as an example. And you want to provide comfort directly after the intervention. And this adorable picture is my niece getting into some glitter and that tiny little footprint behind her. Oh, it's just so adorable. Thought this was just a great picture to really show what toddlers are. This handsome guy is my nephew. I thought this was a great picture for preschoolers, such a ham. When working with preschoolers, we need to use brief and concrete explanations of what we're doing, and we can use things such as magical thinking. So that's saying, we're going to put this ointment on, and this ointment is a very special medicine. And we also want to provide an age-appropriate outlet when they're frustrated. Again, within limits, we want to make sure that we're encouraging them to get out their frustration. Now transitioning into school age, that's my beautiful niece who's now 14, so this was a while ago. We really want to provide an outlet for them to explore their feelings because they're more fearful. So having them be able to explain their fears and being able to talk through it is very important. They typically are very cooperative, but we need to give a little bit more control and involvement in what we're doing, more so than we would with a preschooler or a toddler. This is the toddler that was getting into the glitter, now in the adolescent phase. And when we're considering the adolescent patient, most importantly, we really need to make sure we're involving them in the decisions. It's not us talking about them, but with them, and encouraging self-expression. We need to make sure that we have a good rapport. If we don't have a good rapport, then it's going to be really challenging. And another really important component is really encouraging their privacy and understanding that that is something that they really revere and we need to be mindful of. We need to make sure that, as we previously discussed, we're taking into account the developmental differences when we are educating our patients. So, not only when we administer the medications, but with our education. So, for example, if you're teaching an adolescent about a new medication, we need to make sure that we're doing it in a way that they can receive the information and that they're able to go home and replicate what we've taught them. So that might be doing a return demonstration so that they can see, how do I actually administer this medication? How do I measure it? What are the side effects that I need to watch for? So it's really important that you take that into account and you also include the family into that teaching. Here's one example. If you have a teenager who needs to take their inhaler and they've been forgetting, we need to think of creative ways that we can educate them the importance of taking their inhaler. If we just tell them, you need to do this, it's important, that's not going to be effective. As a teenager, they want to resist and rebel. They want control and they want autonomy. So what is a way that we could try to make it so that they can remember to take it without making them feel forced? Try something like putting it at the sink where their toothbrush is. It's a visual reminder so that they know every day when they go to brush their teeth, they need to take their inhaler. We do need to also be mindful of the risk of abuse and medications with our adolescents, and a lot of education and teaching with the caregivers, parents, family members about proper medication storage and that they need to be secured if it's anything that is a controlled substance. Now we are transitioning into the consideration for our older patients. That picture is of my sweet grandfather, Frank. He passed away in 2021, but he loved dressing up for Halloween, and this was him as Mr. Clean in his 80s. And I thought it was just a really positive picture to show what healthy aging looks like. I do think that we automatically assume our aging population, they can't see, they can't hear, they're confused, and really trying to understand that when you are managing the care for a geriatric client or our older population, please make sure that you're treating them with dignity and respect and not speaking to them as if they're a child. They still have feelings, thoughts, opinions, and it's really important to make sure that we show respect and really try to get away from using terms like old. My patient is old, versus using terms like geriatric or older patient population. This sweet photo is my grandparents. They were married 74 years before he passed away in 2021. They were together since they were 16 years old, so a good chunk of time. You know, it's really important that we take a lot of things into consideration of how our geriatric population is going to be affected in relation to pharmacology. Not just taking into consideration the absorption, distribution, metabolism, and excretion, but other components that can affect their overall health in relation to medications they're taking. Over 85% of older adults greater than 65 years old are taking medications. That's a pretty good number. And not even taking into consideration how many medications are they taking. There's a lot of barriers that we need to look at and assess, whether that's sensory and motor or complexity of their regimen. Little things to think about. We may think, oh, that patient's not taking their medications correctly, they're not being compliant, it's because of their age. That may not be the case. It could be something as simple as the drugs themselves. So let's say your patient is taking a medication that lowers your blood pressure and heart rate. One example, metoprolol, which is a beta blocker and an antihypertensive. Let's say that the patient's not checking their blood pressure or heart rate, and they continue to take their medication, and their blood pressure is now in the 60s. They may not realize their blood pressure is that low, but they're feeling lightheaded, dizzy, foggy, causing them to fall. You'll see automatically the assumption is, well, it's because of their age, or they're taking the drugs wrong because of their age, when really maybe most of these symptoms are from the drugs itself making these situations worse. So really try to look at the situation as a whole before quickly assuming it's purely their age, because it could be the medications causing these side effects. No, I mentioned the complexity of the regimen. One part of that is polypharmacy. When a patient is prescribed multiple drugs, we really need to take a close look at that. You might have 4 to 5 different providers that are ordering medications and not speaking to each other. So the patient thinks, well, all my providers ordered these medications, I should take all of them, without realizing that not one person is realizing what another provider is ordering. This can be very dangerous. So, for example, let's say we have a cardiologist ordering metoprolol to lower the heart rate and the blood pressure. Well, the patient's also experiencing chronic pain, so they're seeing a pain management doctor that's providing a narcotic that's also going to lower their blood pressure. So now they have 2 different physicians ordering medications that are lowering their blood pressure, but they're not speaking to each other. Yes, you would hope that this would be caught at the pharmacy when they're picking up their medications, but that doesn't usually happen. So it's really important that we're addressing polypharmacy within our patients, especially our geriatric population, because the combination of these drugs could be very detrimental and possibly even fatal. We do have this great tool called the Beers criteria, and it's a way for us to determine potentially inappropriate medication usage in our geriatric or elderly population. So this is something that you should be familiar with, and at least be familiar with the name, so that we know how to identify these high-risk drugs and hopefully prevent any adverse reactions from happening. I know I mentioned this multiple times already, but I really want to drive that concept home of making sure that we're assessing all of the barriers that are going to impact our patient, and not just assuming their age is a factor of why they're not taking their medication correctly. A lot of factors such as hearing, vision, are they able to receive or even retain information? Hearing could be a big component. Maybe the healthcare provider explained everything at depth, but they didn't hear, and they didn't want to come across as they couldn't hear, so they just nod their head yes and pretend like they understood the information. You do see that happening a lot. Same with vision. Maybe they didn't read the label correctly, and so they took twice the amount of medication they were supposed to take. So we really want to assess those barriers before that patient goes home and starts taking the medications. So how can we improve drug adherence? And adherence means they're sticking to their schedule, they're taking their medications as prescribed. Sometimes it can be something as simple as we need to write out a schedule for the patient so they know exactly which medications to take. That could be problematic if you have a patient that has vision difficulties. You could also get the cassettes where you're putting the medications in them labeled Sunday through Saturday, AM and PM, so they know exactly which medications to take. Sometimes that can be problematic. I've watched my grandmother put her medications in there and she flipped them and didn't realize it. So that could also be challenging. One of the most amazing technologies that I swear I thought of this and invented it until I saw it out on the market, so I'm pretty sure somebody stole my idea, are machines that actually dispense the medications for you, and they're pretty amazing. So all you have to do is push your button, it dispenses your AM medications. You push your button, it dispenses your PM medications. So a really great way to reduce the issues with any sort of vision or receiving information, as long as you have somebody that's able to help set that up. But a really great, relatively new tool that improves medication adherence. So here's something to think about, just some food for thought. How would you change your patient teaching if you were educating an 86-year-old patient versus a 23-year-old patient? Any thoughts? First thing, assess the situation. You may not change your teaching at all. Maybe your 86-year-old patient has perfect hearing, perfect vision, so your teaching is going to be the same. But most importantly, you need to assess the situation first. Assess your patient's hearing, vision, ability to receive the information. But most importantly, making sure that you're speaking in the same tone and manner that you would for your 23-year-old patient. Don't start raising your voice and shouting at your patient because they're 86 and you assume they cannot hear. Even if your patient is hard of hearing, shouting does not always help. Do little things like ask them, which side has better hearing? They say, well, I hear better on my right side. Okay, go to the right side and speak to the right side closer to so where they can hear you. Shouting at them is not going to help. Also making sure that you're at eye level, give them the opportunity to read your lips. That also helps. So just something to think about. In regard to physiologic changes in our geriatric population, there are 4 main systems we're going to focus on: GI, cardiac, hepatic, and renal. In regard to the GI system, we need to watch for an increase in pH. There's going to be a decrease in peristalsis and motility. So what that means is a slower transit time in the GI tract. There's also a decrease in first pass effect. So when we look at what the effects are going to be with our drug administration, we're going to have a slower absorption of our medications, specifically those that are oral. So can you think of how that might impact the patient? You can look at that in a couple different ways. Slower absorption means it's going to be longer to see an effect of that medication. So we need to take into consideration it may not be the normal onset, peak, and duration that we would expect for that medication. In addition, we also have a higher risk of toxicity with that. Now, with the cardiac and circulatory system, we do have a decrease in our cardiac output as well as our blood flow. This leads to a delay in transit from the drug to the tissue. Again, same concepts as with our GI system. It may not see the same effect that we would expect of that drug because of that delay in transit time. So we might not see the full effect, and it could potentially mean we might need to give more dosing than a normal person. Then with our hepatic system, we have a decrease in our enzyme function and again, decrease in blood flow to the liver. So what does that automatically make you think? If you're thinking an increase in risk of toxicity, you would be correct. Since those drugs cannot be metabolized, we're going to have more in our system. Same principles with our renal system. Because there's a decrease in blood flow as well as just overall functioning nephrons, we're not going to be able to excrete or eliminate that drug like we would if we had a normal renal function, which also means risk for drug toxicity. So we've covered the target organs. Now let's break it down into each of our categories. First, starting with absorption. We do have a delay in absorption in the elderly population, which means decreased blood flow and GI motility. Since our acidic drugs have poor absorption, we're going to have an increase in our alkaline secretions. And as we discussed, if those drugs stay in the GI tract even longer, due to decreased peristalsis and motility, well, we're going to have a delay in onset. So we may not see the typical onset, peak, and duration again, and also risk of toxicity. Now, when we look at distribution, another factor is the loss of our protein binding sites. If you remember from previous talks of what happens when you have free drug. If you have too much circulating free drug, that is high risk of toxicity. So what happens in your aging population? They're going to have a decrease in our albumin levels. Well, what do our drugs bind to? Albumin. So if we have decreased circulating albumin, our drugs aren't going to be able to bind, which means increased free drug and risk of toxicity. Another concept to think about, and this is not just applicable for the aging population, but really anybody. If you're taking in 2 drugs that are highly protein bound, they're going to compete for receptor sites. So if you're giving two drugs concurrently that are highly protein bound, one of them is going to win and the other is going to lose. So what happens to the losing drug? Risk of toxicity. So you always want to be mindful that you're not giving two highly protein bound drugs together, especially in your aging population due to that decrease in our albumin and binding sites. There's also a reduction in our total body water, which means we're going to have a higher concentration of our water-soluble drugs. Higher concentration equals toxicity. With aging, you're also going to have an increase in your fat and decrease in lean muscle mass. So what do you think might happen if we have an increase in fat? Well, our lipophilic drugs are going to be distributed to those fatty tissues, which means prolonged drug action. That leads to my favorite word of this topic, toxicity. The main concept to drive home with metabolism is we're going to have a decrease in blood flow to our liver. So if we have a decrease in blood flow to the liver and a decreased capability for enzyme functions, what do you think is going to happen? If you said toxicity, you're right. That means we really need to watch the liver function very closely. But just remember, even if our LFTs are normal, does not mean we don't have impaired hepatic function. So it's really important that you're watching for those signs of toxicity. And our last, but just as important category, excretion or elimination. So after the age of 65, you're going to have another 35% decrease in your functioning nephrons. That does not include the already big hit that you've taken with each decade. According to the National Kidney Foundation, your kidney function actually starts declining at the age of 40. They project that you have about 1% loss every year after 40. I don't know about you, but I really don't like those statistics. Then when we get to after the age of 70, we have an even bigger decrease, 40% in our functioning nephrons. So we really need to watch our renal excretion very closely. And that's not just looking at overall renal function, creatinine, BUN, and GFR, but we're also looking at our urine output. That has a factor as well, and we call that our intakes and outputs, so making sure our I and O's are balanced. Is what is going in, coming out. As I'm sure you've already anticipated what I'm going to say, impaired renal function leads to drug toxicity. So again, we've talked about it previously, but just to reiterate, if you do have an older client, we may do renal dosing where we'll decrease the dose just to make sure that their kidneys don't take a hit. But we'll still want to monitor the renal function, especially with the nephrotoxic drugs.